Good afternoon, and thank you once again for joining us today on this day when we are commemorating World Psoriasis Day 2025. Thank you for joining us. I would like to take this opportunity to introduce our speaker for today. She is Dr. Priscilla Angwenyi from KNH. She's a consultant dermatologist and also a junior counselor at the International Psoriasis Council. So I would like to invite Dr. Angwenyi to pick up from here and sensitize us more on psoriatic disease. Dr. Angwenyi, the floor is yours. Karibu.
Thank you. Thank you very much for that kind introduction. Welcome everyone on this World Psoriasis Day. So I shall share my slides. So today we shall be discussing psoriatic disease. It's no longer called just psoriasis. We call it psoriatic disease because we realize that it is a spectrum of various things that I shall discuss as we continue. On my slides, just give me a minute. Can you see my slides?
We saw them briefly and then now we can see.
Then they disappeared. Okay.
Yeah, just reattempt sharing again.
Okay.
So perfect. We can see.
Okay.
Yes, we can see it now.
So, that's perfect. So psoriatic disease is a chronic multi-system immune-mediated disease. It is commonly characterized by the scaly plaques that you see on the skin that I shall show you later, painful joints, nail dystrophy, which essentially means nail destruction, and comorbidities affecting majority of the organs in the body. And indeed, the theme this year is a focus on the comorbidities associated with psoriatic disease. Studies done in different areas have all found that it affects 2% of most populations, and there is an equal male to female ratio. We have two peaks of onset, 20 to 30 years, and then again after 40 years, but it can affect any age. We have seen babies, we've seen elderly patients with psoriatic disease. So what is the pathogenesis? Psoriatic disease develops as a complex interplay between genetic factors, the immune system, and certain environmental factors. And the genetics that we found is that it runs in families. More often when you're taking a history from a patient, you'll find they'll say a grandparent or a sister. I've seen even twins who have psoriatic disease. And this is associated with what we call the SOR1 loci on the MHC HLA genes. So that is the genetic aspect. The environmental aspect involves several factors. So there is injury, what we call Koebner phenomenon, which means where there is a site of trauma on the skin in a patient with psoriatic disease, the patient will develop similar lesions that are similar clinically and also histologically, were you to take a biopsy, to the other lesions that the patient has. So things like a cut or with an injection site and all that, they will develop psoriatic lesions on those areas. Infections, streptococcal pharyngitis has been found to be a trigger, especially for psoriatic disease, mostly in the young people, the children. Viruses such as HIV, we are seeing a rise of psoriasis, more so in this setup where we have a high prevalence of HIV. Drugs such as lithium salts, beta blockers, NSAIDs, particularly indomethacin, antimalarials, particularly the chloroquines. Stress is a big factor with psoriatic disease, and it actually poses a 20-fold risk. Sun exposure leading to sunburn, not just normal sun exposure. And in fact, most patients will say their skin improves when they're exposed to sun. However, if they're basking in that sun until they're burning, similar to what we talked about up there on the Koebnerization, they will develop psoriatic lesions on those areas of sunburn. Smoking, and particularly Smoking will cause a particular type of psoriatic disease where they get lesions on their palms and the soles. We call it palmoplantar psoriasis. Alcohol worsens psoriasis, which now is a vicious cycle. Most patients with psoriasis are struggling with mental issues, anxiety, depression, which may lead one to drink more alcohol. And that alcohol in turn makes the disease worse, which in turn makes the patient even more depressed. Obesity has a 35-fold risk, and it has been found as just obesity by itself is a risk factor for developing psoriasis, and hormonal changes. So their patients, most patients, for female patients, when they get pregnant, the disease will sort of settle. For some, it may even resolve completely. And once they're in that postpartum period and the hormones are changing, they do get even a worse disease than they had before they got pregnant. So what is the immune response in psoriatic disease? We've discussed genetics, environmental factors. Now we discuss the immune response. So there is activation of the innate immune system that is driven by endogenous cytokines, which will coexist with autoinflammatory perpetuation of T-cell-driven autoimmune reactions. And this mechanism overlap and potentiate each other, which means that in psoriatic disease, there is an initiation and maintenance phase. So there's been the activation, and now there are certain cytokines that maintain that disease, making it a chronic illness. So studies have found that psoriatic disease is mostly a Th1, Th17 inflammatory condition. I'll explain. So how does it begin? The dendritic cells are playing the major role. They're called sort of the quarterback in the initial stages of the disease. So a patient will have trauma to the skin, what we've said, a cut, an injection, some sunburn. And when that happens, there's release of antimicrobial peptides. These peptides will combine with that damaged keratinocyte, which is the skin of the cell, and form a complex. Now that complex stimulates what we call toll-like receptors that are part of the immune system in the skin, and there'll be production of interferons. Interferons cause maturation of more of the myeloid dendritic cells. With that, you get Th1, Th17 differentiation, which produces more interferon gamma and interleukin 17. Now, these activated myeloid cells, which are activated by the interferons, will migrate into the lymph nodes, draining that area, secrete more cytokines, TNF-alpha, interleukin 23, interleukin 12, which now will cause proliferation of Th17 and Th1. So it's a cycle. It was initiated before, but now these dendritic cells are maintaining that inflammatory milieu, if you may call it. Other cells which are there are the monocytes, which are now going to secrete more TNF-alpha, interleukin 12, interleukin 23. And what has been found is that the Th17 has pro-inflammatory effects and is involved in the inflammatory loop between those dendritic cells that were responding earlier and the keratinocytes, leading to overproduction of antimicrobial peptides, inflammatory cytokines, chemokines, and all in all causing an amplified immune response. So the patient's body has a heightened immune response, a very high inflammatory milieu, so much inflammation going. And this is what now activates keratinocyte production, which is the scaly lesions we see neovascularization and all that. And giving you the classical picture of psoriasis, which is this. So I don't know if you can see where my pointer is. Those are the scales that you see, those keratinocytes that were being produced and more being produced at a faster rate. Indeed, they say for psoriatic skin, you're producing new cells almost every 4 to 7 days, as opposed to the general population where it should be 28 days. So they get those thick scales, which is what you'd see under the microscope. The skin is thickened, what we call acanthosis, which is that. Then you have the inflammatory cells in here. You have neovascularization, these reddish, pinkish that you're seeing are the blood vessels that are, they're called tortuous dilated blood vessels that you would see. And the previous image was what I was describing with the immune response, the keratinocytes, the cytokines, dendritic cells, macrophages, lymphocytes, Th17. So a whole inflammatory milieu in the patient's body. So what are the clinical features of psoriasis? There is a classical presentation where they get well-defined scaly patches and plaques on the skin. Most often it will affect the extensor surfaces, the elbows, lower back, knees, shins, and scalp, and it is symmetrical. However, it can affect other areas and appear different from this classical picture. I'll show you exactly how. So this is a classical psoriatic lesion. So very well-defined, very thick, scaly plaques. Most books show, of course, in the lighter skin, so they'll appear erythematous, but for our skin, we get very dark gray plaques, as you can see. With that scale, and if you try to sort of scrape off the scale, it bleeds, what we call the Auspitz sign, and that is pathognomic of psoriasis. This is the scalp of a patient. You can see those very thick gray scales. And what is unique about psoriasis, there is no hair loss, as you can see. No hair loss, the hair is intact, but the patient has these thick scales. They tell you when they go to the salon, no one wants to touch them. They assume it's fungal. It is not fungal, it is psoriasis. And we are raising awareness so that we can reduce the stigma for our patients. This is now, so that was psoriasis vulgaris, the commonest, the first picture. We had scabs called psoriasis. Then we have a special type called guttate psoriasis. Guttate means like raindrops. You can see these scales are very tiny scales all over the trunk, or the abdomen of this patient. And for this particular patient, I remember her, she clearly gave a history of having a throat infection prior to the development. And guttate is mostly found in children, guttate psoriasis, and it is often triggered by a streptococcal pharyngitis. Then weeks later, the patient develops these types of raindrop-like scaly lesions. Then we have an inverse psoriasis. So we say psoriasis often affects the extensor surfaces, the elbows, the shins, the back. But inverse now means the opposite of that classical. So this is when it's affecting the folds, the axilla, around the umbilicus. You can find it in the groin, and the scales will not be as thick as the others that you saw before. Then we have another type called pustular psoriasis. Pustular psoriasis is a dermatological emergency. You can see this patient now is very red. You can see those tiny pus-filled lesions, and some are even joining up together to form what we call lakes of pus. This is a dermatological emergency because when the patient presents with this, they often have now even systemic effects. They're having side effects that are affecting the major organs of the body. And when you see a patient who had psoriasis and has developed this, you need to refer them urgently to where they can get that dermatological support. Sometimes they may even need to be managed in a HDU. Another dermatological emergency that occurs in the setup of psoriasis is the erythrodermic psoriasis, where the patient is very red, as you can see with this gentleman. You can hardly see any plaques, but the patient is red. And most of our population, the patient may even appear bluish black. Now, what I'll say about both of these two, the pustular psoriasis and the erythrodermic psoriasis, they are often triggered by giving systemic steroids to a patient with psoriasis. And you see, oh, the patient has gotten better, and then you stop the steroids, and now this is what happens. So throughout this talk, I will plead with you, please do not give prednisone, do not give the injectable steroids to psoriasis patients. If you are unsure, please refer. I will talk more about different treatment modalities you can use in psoriasis. But for now, mark these two photos, maybe commit to your memory, pustular psoriasis and erythrodermic psoriasis. These are emergencies and the patient must be admitted, given that support the kidneys, support the heart, and all that, because it's a skin barrier failure. We have nail psoriasis. Sorry, I've used more of a Caucasian picture. I couldn't get a picture with our skin that would demonstrate the changes I wanted to show. So you have what we call onycholysis, where the nail is destroyed, as you can see from underneath. That there's a destruction underneath the nail, on the nail bed. You get pitting, you get ridges, as you can see with that. And often with nail psoriasis, you're concerned that the patient is going to end up developing psoriatic arthritis, which is psoriasis affecting the joint. So the theme for this year is a focus on psoriasis comorbidities. And indeed, psoriasis has been found to affect virtually all the organs of the body. So we shall start head going down. They have the psychosocial burden. They get depression, they have higher suicidal ideation, alcoholism, anxiety. They don't want to socialize because they're embarrassed about their skin. People think they're that. People think that they have fungal infection. And now with more and more, we are raising awareness so that we can have these people be supported in our societies. So we have that affecting the patients. And there is ocular inflammation where you can have iritis, uveitis, episcleritis. So with a psoriatic patient, it's important to have them seen by the ophthalmologist on a regular basis. They can get metabolic syndrome with the hypertension, dyslipidemia, diabetes, obesity, and generally patients with psoriasis have a higher cardiovascular risk. The gut can be involved with the inflammatory bowel disease, Crohn's disease, and ulcerative colitis. You can get psoriatic arthritis, as I alluded to earlier. Other things that the patients can get is a non-alcoholic fatty liver disease, chronic obstructive pulmonary disease, obstructive sleep apnea. And what has been found with all this is that high inflammatory milieu in the body is what triggers all this. And in fact, patients with psoriasis, because of these comorbidities, have been found to have even a reduced lifespan compared to the general population. That because of these comorbidities, they are likely to live 6 years less than the general population. So for this year, the focus is screening of patients for the comorbidities and treating the patients. If need be, have a multidisciplinary team involved. If possible, have a psychologist on board in your clinics. And also we have the Psoriatic Association of Kenya that was founded by the late Dr. Hosea Waweru that offers a family or a support group for these patients. Because if they're having suicidal ideation, you don't know who may attempt to end it all. So let's support our patients. Let's screen for the comorbidities and manage them. And in fact, has been found if you treat the psoriatic disease earlier, you're less likely to develop these comorbidities. So let's catch them early, let's treat them earlier. So how do we treat psoriasis? We divide psoriasis into mild or limited disease and severe disease. In between there's moderate disease, but that will take your clinical acumen to see where to place your patient. So for mild disease or limited disease, we focus mostly on topical therapy. Then we have this severe disease where we use systemic therapy, often in combination with the topical therapy. Now, just as a note, even as we say limited disease is mild, there are certain cases where it may be limited, but it's affecting the patient's quality of life. Those are what we call where the psoriasis is affecting a high impact area. If it's affecting the genitalia, affecting the palms, affecting the soles, affecting the scalp, affecting the face, even if it's just 1% of that patient's body surface area, that is enough to consider it as a severe disease and enough for you to the patient with the systemic therapy. When else do you classify it as severe disease? If there's more than 10% body surface involvement. If they score more than 10 in the DLQI, DLQI is a dermatological life quality index, where you ask the patient a certain number of questions, given the past week or so, how it has affected their day-to-day life, social activities, relationships, and work, and then you score. If they score more than 10, that would be considered severe disease. And also, if you've treated the patient and they failed on topical therapy, don't keep forcing and say, you must continue applying this cream, and if it's not working, the patient is getting affected. We've said the psychosocial aspect is very important in psoriasis. Then you can give systemic therapy. And as I mentioned, and I keep mentioning, psychological support is vital, and it involves even the patient support groups and even bringing in psychologists and even psychiatrists when necessary. So what topical therapies do we use? We use emollients. Emollients are the moisturizers, not milking jellies, moisturizers created to now just soothe that skin, help with maintaining the skin barrier, as we talked about earlier, that there is that affecting the skin barrier. We use topical steroids, but I will insist and say this must be used judiciously. What does that mean? Don't give a steroid and apply for 5 days, stop it. Give the patient the moment that the skin has cleared, stop it. What happens if you keep doing that start, stop? They can get rebound flare. Or worse, if they were playing on a very large area, you can end up with those dermatological emergencies we talked about, the pustular and the erythrodermic psoriasis. So you give steroids, but when you feel like you need to scale down, you taper. If you are playing twice a day, go to once a day, go to alternate days, maybe 2 times a week, and you go just gradually. No random start-stop measures with the topical steroids. And if unsure, feel free to consult a dermatologist. We have the vitamin D analogs, the ones that we have in our market, mostly the calcipotriol. We have topical retinoids, calcineurin inhibitors, the tacrolimus and pamecrolimus, anthralin, which is dithranol. We have Colta that can be used, and we have phototherapy, which we actually offer at KNH in our dermatology department. We use the narrowband UVB phototherapy for patients, and they can come twice a week, and they receive the therapy under the supervision of our doctors and nurses. We have systemic agents that are used in psoriasis. We have methotrexate, quite affordable and widely available. It's quite commonly used. And this one is useful because it can work both on the skin and on the joints. Cyclosporin is another agent, although it's a bit expensive, but it works very fast and very well for psoriasis. We have the systemic retinoid acitretin that is quite useful. However, I'll give a caution, do not give to women in reproductive age. Acitretin will stay in the body for 3 years after you've stopped it. And it is known to cause very severe teratogenicity in the fetus and also can cause spontaneous abortion. So even if a patient tells you they're not sexually active for this one, just avoid. Do not give to women in their reproductive age. And then we have biologics, which are the new kids of the block and the big thing now for psoriasis. And I'm proud to say even in Kenyatta, we are offering biologics. We have TNF-alpha agents that can be used, interleukin-17 receptor inhibitors, and interleukin-12 and 23 inhibitors. If you can remember from that discussion of the immune system, these are molecules that target aspects in that immune system response to control the disease. We don't have a cure for psoriasis as yet, but we have these agents which can help a patient live a long and full life. We have small molecules, and even this, we are offering them now. We have the phosphodiesterase 4 inhibitors, such as apremilast, which is available locally. And we have the Janus kinase inhibitors, such as tofacitinib, that are also available locally. As you give these agents, the systemic agents, I will urge you to consider the age. As I've said, if it's a young lady, you're not going to give the acitretin. If she's newly married, you're not going to consider methotrexate. You'll use something else. Comorbidities, if they have hypertension, you're not going to give cyclosporin. You know what it does to the blood pressure. The cost, how can the patient afford? There's no use of writing a medication the patient takes for 1 week and then they can't sustain it. You'd rather give something affordable and they're able to sustain it and they get the resolution of their symptoms. the desire to conceive, as I have alluded to earlier, the likelihood of adherence. If you feel a patient will not be able to take a tablet every day, you may give them something that they may have to take. They can take weekly or twice weekly. If they are not able to come for the phototherapy twice a week, there's no need of forcing, and they have to travel from very far. They won't come, so it will not work. You give a patient that, a medicine that you think, a treatment that you think the patient will be able to adhere to. Then the treatment goals. What are the patient's treatment goals? For psoriasis, it's more of a patient-directed treatment that you do. You ask the patient, what do you want? The patient will tell you, if I can just get my hands not to be rough anymore and I can shake people's hands, I will be happy. For some, they tell you, that one is hidden on my back. I just want you to control the itch or the pain. Psoriatic patients do have skin pain. So discuss the patient's treatment goals, then you work with the patient towards that. As I will keep emphasizing, please do not give systemic steroids. Do not inject these patients. Don't give prednisone. You'd rather refer and save the patient's life. Indeed, we have seen mortalities even with the two emergencies I showed you earlier. So do not give systemic steroids for these patients. So in conclusion, psoriasis is a chronic, multisystemic, multifactorial immune-mediated condition. It greatly affects the patient's quality of life, and the patient should be routinely screened for the associated comorbidities, as this contributes to a reduced lifespan in these patients compared to the general population. Psychological support is key in the management of psoriatic disease, and my running theme, do not give systemic steroids. Thank you very much for listening. All right. Nelson, I can.
Yes, thank you, Dr. Ngwenyi, for the wonderful presentation. I think I am more informed about psoriasis now. I would like us to shift a bit to Q&A. We have received some questions, and also just to say you are receiving appreciation from our participants as per the emojis you can see on your screen.
Thank you very much.
So our first question for today is from Dennis Nyakundi. He is asking, what is the difference between psoriasis and dermatitis?
Now, dermatitis means rash, and often dermatitis is, most times when someone is saying dermatitis, they are talking about maybe eczema or atopic dermatitis, which is very different. Now that is a complete, in fact, those are the two diseases that are compared when teaching, because they are teaching the immune system. They are two different conditions. The atopic dermatitis is a Th2 condition. The triggers are completely different. Psoriasis is a Th1 condition. So with atopic eczema is a whole topic in itself, but they are different. They are different. So I'd say psoriasis is Th1 mediated, dermatitis is Th2 mediated condition. And now it will be more related with allergies, asthma, allergic rhinitis, allergic conjunctivitis, which we do not see in psoriasis. I hope that helps.
All right. Thank you. Over to our next question. One question I also had myself. Kindly clarify, when you talk of psoriasis comorbidities, do you mean psoriatic disease can cause other conditions you have highlighted?
Yes, that is what has been found, that patients with psoriasis, even young ones in their 20s, they are seeing, because of that inflammation. Before, psoriasis was just thought to be just the skin. But then it was found, as we are following up these patients, they are getting hypertension, diabetes, cardiovascular disorders. Their bowels are getting very inflamed and irritated. So what studies have found is, because of that inflammation that we are seeing with the Th1, Th17, it's not just limited to the skin. It's going and affecting the joints, going and affecting the heart. the liver and all that. So yes, it does cause those conditions. And now the focus is when you meet a psoriatic patient, immediately you should screen, even someone in their 20s. You should screen, and routinely as you see them, screen. For the psychological, talk with them, ask them, how are you feeling? How's your week been? How has this affected you with your hobbies, with your relationship and all that? So yes, it does cause those other conditions.
Okay, thank you. Now to the next one. Is the phototherapy the same as the one we use in units for jaundice?
No, it is not the same. This one now we are using what we call, we use either narrowband UVB or we use PUVA, which is the UVA directed. It's very, very different from the one for the neonates.
Okay. Our next question is from Mwashira Njuguna. How do you clearly differentiate psoriasis from eczema and also HIV-related skin reactions and eruptions?
Okay, so how do you differentiate? Most times it's how it presents. With psoriasis, from those photos I showed, it's often very, very well defined, very, very well defined scaly lesions. But with eczema, they are ill-defined. You'll find they have a rash here, that they're almost overlapping each other. But at the end of the day, what will differentiate the two is a skin biopsy. You saw the skin biopsy I showed with the psoriasis. For atopic eczema will be very different. So if you're unsure, you can do the biopsy or you can refer to a dermatologist to do the biopsy, and on histology you will see. But also there will be other related things, as I said. With atopic eczema, they'll mention a grandmother had asthma, a sister has allergic rhinitis. But with psoriasis, there'll be no relation with any of those atopic diseases. It will be very clear. Either they're the first person in the family, or they'll tell you someone had exactly similar lesions like this. So that is the difference. Biopsy, do a biopsy.
Okay, thank you. Next question is from Catherine Jerry. She's saying you have not told us to give systemic steroids. Please, can you? Sorry, let me start again. You have told us not to give systemic steroids. Please, can you explain?
I have said do not give because they cause a flare, a rebound flare, and particularly with systemic steroids. The psoriasis, what we mean is that the psoriasis will act like it is clearing. The moment that steroid is clearing from the body, be it an injection, you won't inject every day. You inject once, maybe you tell the patient to come after 1 month, or if it's even with the tablet, prednisone, you won't give 100 milligrams forever or 10 milligrams forever. At some point, you will want to take them off. You cannot give steroids forever. When you want to take them off, patients get a rebound flare, meaning all that psoriasis you thought had cleared will come back, or worse, they will develop the pustular or erythrodermic psoriasis, which, as I said, is life-threatening. Why is it life-threatening? You have loss of the skin barrier. With loss of the skin barrier, you can't control temperature. You're losing fluids. The patient, now the kidney is getting affected. They're having a high output cardiac failure because the heart is working so hard to control, what you have lost from the body, control the temperature and all that. So do not give them. You will cause harm to this patient. You can give topical, but even with topical, you don't withdraw them suddenly. I see a tendency of a patient being given steroids for 5 days, 2 weeks, then you stop. If you fear steroids, topical steroids, do not give them. You'd rather refer. Or if you're going to give, maybe you're in a far-flung area and the patient cannot come to Kenyatta or where there's a dermatologist. Give them when the disease starts to clear, taper them off slowly. If you're giving twice a day, reduce to once a day, then reduce to alternate days, slowly, slowly. But that withdrawal is what causes that rebound flare and the development of what you call the unstable psoriasis, the two dermatological emergencies I showed in relation to psoriasis, pustular and erythrodermic. Do not give steroids, please.
Okay. Our
Yes.
next question is from a participant from Kiambu County. is how do you differentiate psoriasis and plague stage mycosis? This last word is apologies if yes, correct,
Yes,
yes.
they will be very different. The hallmark of mycosis fungoides, particularly the plaque stage, is the epidermotrophism, which is the abnormal lymphocytes lining up at the dermoepidermal junction and heading into the epidermis. With psoriasis, what you're seeing, the hallmark is parakeratosis, which are those cells retaining the nucleus. And that histology that I showed you, you will not, it's very, very classical for the two. So you have a typical lymphocytes in mycosis fungoides with epidermotrophism. You have parakeratosis with a regular acanthosis. So it's histological is how you would differentiate the two.
Over to the next one from Lorraine Onzera. How would you go, rather, how would she go about treating a patient with type 1 DM, hypothyroidism,
Thyroidism,
who also has mild psoriasis?
I would give a topical agent, be it a calcineurin inhibitor, vitamin D analog, or a steroid, and I'll refer to an endocrinologist. Let's not own patients. I mentioned multidisciplinary. Let's not own patients. At the end of the day, do what is best for that patient. Type 1 DM, hypothyroidism, please refer to an endocrinologist.
Okay, thank you. Margaret Obura is saying, thank you for the good presentation. Can you also give antifungal orals for the management too?
No, you cannot. As I said, it is not an infection. It is contagious. You do not give. There is no role for antifungals unless you have confirmed a fungal infection. If it's pure psoriasis, no, there is no role for antifungals, whether topical or oral.
Okay. Next question is from Brighton. Um, treatment, what is the treatment of nail psoriasis in pediatrics?
Now, with nail psoriasis, you need to weigh benefits versus risks. Nail psoriasis will hardly ever respond to topicals. It requires systemic agents. With systemic agents comes side effects. So you check, is it worth to the patient to give them, let's say, methotrexate? So you weigh. So how it's treated, it's systemically, systemic agents. But with anything that you give to a patient, you always weigh benefits versus risk. For a child, would I rush to start immunomodulation? No, I would not. I would just encourage a child, tell them they're beautiful, they're smart, unless it's really destroying the nails. And in that case, I would discuss with the parents the benefits versus risks, and then you can initiate a systemic agent.
All right. Jackson Sitoya is thanking you for the brilliant presentation. He's also asking, I
Thank
think this
you.
is mine. He's also asking
Mm.
if the notes can be shared via email. Jackson, just to note that all of our sessions are recorded and are uploaded to our YouTube page for your reference. So this one will be uploaded as soon as tomorrow morning. You can visit our YouTube page, just search the topic or search for KNHUN webinar, and the topic you'll be able to find this session recording there. To the next question, a participant who will remain anonymous. I have a son with all these classical symptoms: nail, skin, around the left eye, node, and ears. Have interacted with a lot of dermatologists. I've also tried antifungals, etc. How can I reach you for review at KNH, or how is the procedure? How can she come for her son to be seen at KNH?
We have 2 dermatology clinics in Kenyatta on Wednesday mornings for pediatrics and Friday mornings for adults. So if you're referred to KNH, you can be seen at any of those clinics. We'll be happy to see your son or any other patient with skin issues.
Okay. All right. Thank you. Another question is, how can we differentiate between psoriasis lichen planus, and rheumatic fever rashes?
It would be histology. A skin biopsy for histology would help with that.
Okay.
Mm.
I can see the questions are still coming. There's one from Isabella Orege. Most inflammatory skin conditions are similar and spot diagnosis can be challenging. What are the routine screen procedures for psoriasis that healthcare providers in the primary healthcare setting can perform?
I agree with that. Spot diagnosis is difficult. So the routine would be take a history. Dermatology is mostly based on the history of a patient. A patient can present with something that looks very similar. So one may have taken a drug, one may have inherited it, another may be an infection. So history, and then when you're at a hard place and you still can't make a diagnosis, take a biopsy, send to a reputable pathology department for that histology, write your differential diagnosis, write a proper history. It's not a guesswork game for the pathologist. Tell them what you're seeing, give them differentials. They will give you a diagnosis that you can put together. Primary healthcare setting can perform. It's still the biopsy for histology. That is what you can do.
Okay. We have another question. I don't know whether this is related with the last one we handled on HIV, but the question is, what's the difference between HIV rash and psoriatic skin condition?
There is no such thing as HIV rash. HIV can present with a myriad of things, including psoriasis itself. So there's no diagnosis as HIV rash. They present with a wide variety of skin lesions, including psoriasis itself. But I will say that most times HIV with psoriasis will have the inverse psoriasis, which I said is in the folds, in the axilla, umbilicus, the groin. It's not equal to HIV, but most times that is what they present with, and they present with a very difficult to treat psoriasis. So you need to sort out the HIV, the CD4, the viral load as you manage the psoriasis as well.
Okay, thank you.
Yes.
We have another question from an attendee who will remain anonymous as well. He is from Homa Bay. He's saying his family, especially his grandmother, is suffering from psoriasis on sore feet. Also, him when he was young, he used to suffer, but now they are disappearing as he grows older. His question is, will some of the type of psoriasis get healed without treatment over time?
There are patients who get resolution of their symptoms. As I said, even those who, when one gets pregnant, it can resolve. But more often than not, it will come back at some point. So have it in the back of your mind that yes, there was psoriasis here, so that when it comes back, you're not surprised. I'm not saying it can never disappear completely, but there are those it resolves, they say for a few years, then it comes back. As we said, anything can trigger a stressful condition. You get a throat infection. Anything can trigger it from those environmental factors that we discussed. So yes, it does resolve, but most times it comes back.
Okay. Another question is from Collins Kiprono. What is the difference between onychomycosis and nail psoriasis?
Onychomycosis is the fungal infection. So if you see a patient and they have nail changes, and you've checked all over the body and you can't find any skin lesions, you now will need to take the nail clippings, you do the KOH, the potassium hydroxide, you look for the fungal elements. Then you will find if there are fungal elements, that's onychomycosis. Nail psoriasis will very rarely just appear as just nail changes. It's often the skin, then comes the nails, then comes the joints. So look for, if you're suspecting psoriasis and they have a patient just comes with nail issues and you think it looks like psoriasis, check the skin, check the scalp for skin lesions. If none, take some nail clippings, send them to the lab to check for fungal elements and yeast and all that.
Okay, thank you for that response. This is coming from the other HIV question you answered. Um, how do you manage? It's from Asila Balanya. How do you manage persistent HIV rash?
I don't know how to answer this.
I think we might
Uh,
need to have you
yeah,
on
just
on the
refer
platform.
to a
Yeah.
dermatologist. Yeah. Mm.
Okay. All right.
Mm.
Thank you. Another question from an anonymous attendee is thank you for the talk. What is the duration of topical therapy that requires tapering down?
You do it until the lesions clear or they've remarkably improved. And when they've done that, you start going down slowly, as I said. You start reducing the frequency slowly. So you can extend it. So you don't have an end point, that they say, 1 month or 2 weeks. So you do until the lesions have resolved or are markedly flattened. They barely have any lesions, and you start slowly going down. If it was twice a day, you start going to once a day, do it for like 2 weeks or even 3 weeks, then alternate days, slowly, slowly. If you're on a very strong steroids, start going to a lower strength, slowly, slowly. There's no rush to just abruptly stop them. As I said, if you fear using steroids, do not use them. You'd rather use another agent.
Okay. I have appreciations here. We have from
Thank you
Kiambu
very much.
County. They're thanking you for the
Thank you.
presentation and also answering their question. We
Thank you
also
very
have
much.
appreciation from Jacqueline Genga saying this was very informative, timely, and necessary. Dorcas Mumo it has a question here. Is
Mhm.
psoriasis more prevalent in blacks or the whites?
Right now, most of the studies have been done in the Caucasian population. So they say, in fact, certain studies even say, oh, there's no psoriasis in Africa, which is not true. I see so many in the clinics and in the wards. So what studies have shown, they say it's more prevalent in the Caucasian. I don't 100% agree with that. It just shows we have not done enough studies on prevalence in our population. And we are getting there step by step.
Okay. Another question here is Kaposis and psoriasis coexist. Is it possible one can cause the other?
One cannot cause the other, but they can coexist. A patient can have Kaposi sarcoma and have psoriasis, but they're not related. It can just be a coincidence that they have occurred, but there's no relationship between the two.
Okay. We have a question, I think, from a parent in the audience saying, my son, 3 years old, has eczema.
Mm.
They are currently managing it with Momate cream, and they're
Mm.
asking, what are the long-term effects of using it? And can the eczema eventually go away?
uh, oh, that's tricky. If they're used, if it was prescribed by a qualified physician, you should not be worried because they will give it for a specific period and they know how to get your son off. For atopic eczema, most children outgrow. Not 100% of them, but most. As they're approaching school going age, most of them outgrow. So that happens. So you can still remain hopeful that he's only 3. As he approaches the age of 5, 6, 7, it can clear. But for the medication, I'd advise you see your doctor, express your concern. If it was a qualified physician who prescribed it, they will know how to get your son off it. But with eczema, there's no separating steroids. That is the main management for eczema. So do not fear the steroid. Trust the doctor and have them work out a plan for your son.
Right. Thank you. The next question is from Dr. Adede Ajoni, uh, saying, I am an emo venerologist. They're asking, it seems to have taken long for a postgraduate diploma in dermatology. They're asking if are there any challenges on that side if someone would like to pursue that as a career.
No, I think you can look for programs that are available to you and you apply, but that is beyond the scope of my expertise.
Oh, okay.
Yeah.
All right. A question from an anonymous attendee. What could be the possible cause of skin irritation and itchiness after taking a shower?
That is often what we call aquagenic urticaria. So you would need to go be investigated. Sometimes the cause can be found. There are various tests that can be done, blood works and all that to find out the cause. So I'd say visit a dermatologist near you. They can investigate and see what is the cause and institute appropriate management.
Okay. A question, I think it's the second last question from Winnie Nyabuke. What is the difference
Mhm.
between seborrheic dermatitis and psoriasis?
Seborrheic. Seborrheic
Yes.
dermatitis is often triggered by a yeast. We see it mostly in children, babies under the age of 1. We see it again a lot in teenagers as the hormones are starting to act on the sebaceous glands. And we see it in HIV quite a bit. So they get these very greasy scales related to a yeast malassezia. Psoriasis, as we said, it's a chronic immune-mediated condition, so very different. It takes a skill to differentiate them clinically, but if you're interested, you can just go online and Google seborrheic dermatitis versus psoriasis images, then you can see how they look
Okay.
different. Now that is the difference. One is malassezia, yeast infection, the other one is immune-mediated condition.
Okay. Another question is how do you differentiate scalp psoriasis from ringworm?
Ringworm will have the associated hair loss. You remember with the photo of scalp psoriasis, I showed you that the hair was very much intact. They just have these scales. With ringworm, which is now tinea capitis, not ringworms of worms in the tummy, as most people assume. It's called ringworm because of it's round. So you'll have that round lesion, annular lesion on the scalp, most times in primary school age children, and there'll be hair loss in that area. With psoriasis, the hair is intact. They don't lose their hair.
Okay. I think this is the last question from Zipporah.
Mhm.
What is the treatment to those having itching skin after taking protein food?
Okay. I do not ascribe to allergy to all protein food, which we see a lot of children being stopped from eating protein. Then we end up with protein energy malnutrition in 2025 in very affluent families. If you're feeling you're having an itch when you eat food, we have now allergy clinics all over, particularly in Nairobi. They will do specific tests to specific foods. Do not do a blanket stopping of protein food. And this one maybe goes to everyone. Don't see a child itching and just say, Mama, stop everything. And even you, Mama, even though you're breastfeeding, stop protein. You're going to cause malnutrition. Go see an allergy specialist. They will do the test for specific foods and other triggers, and then they will advise. And then based on that, a treatment plan can be instituted. So what I'll say is seek care from an allergy specialist, let them run the test, but do not rush to stop all protein foods, particularly in children. It causes more harm than good.
All right. I think one last question. So just
Mm.
come in. The Madura of foot involving knees. How do you differentiate from psoriasis of foot?
They're very, very different. Madura, they'll have nodules and sinuses that are oozing granules. They'll have been sick for years, even 20 years, no pain. They'll tell you they remember injury from a thorn prick or something. More often they're harders somewhere or nomads. Very, very different. Psoriasis is scaly plaques. Just those photos I showed of the scaly lesions, scaly elevated plaques. Madura, very light. The foot is swollen, it has nodules, it is oozing, and all that. So very, very different. I propose you just look at photos. We're glad to be living in the age of the internet. You can just put this versus this. So that's, I mean, dermatology is seeing. So the more you see photos, the more it will be easier to identify something, especially if you're far away from a dermatologist. It helps. Take your time, just Madura versus psoriasis. You'll see the difference.
Okay. Thank you. I think that's the close of the Q&A section.
Thank you.
Judging from all of the reactions, all of the appreciations that are coming in, and also the wide array of questions that we've gotten from this particular talk, I can say that we would like to have you once again for more dermatology sessions, Dr. Angweni.
I'm happy
So,
to. Thank you.
karibu tena sana. Just for the last announcements for this session on this session. Kindly note that this session, as we said at the beginning, will be uploaded on our YouTube page. So you can always visit, watch it for your reference, send it to someone else who might be interested to follow the talk. And you will also get our past recordings. All of our webinars have been uploaded to that YouTube page. On our upcoming sessions, we have one upcoming session today in the evening. This is in preparation for the Society for Quality Healthcare conference. And this is a pre-conference webinar. They will be speaking on aligning hospital quality and patient safety programs. This will be part 2. Part 1 took place last week, and the recording is also uploaded. Tomorrow, we will be having a talk on targeting the source, effective spasm control in abdominal pain. Do join us for this one. It will be a quite interesting one. And on Friday, we will also be having a team from Nairobi City County. This year, we will be having the second Nairobi Health Scientific Conference 2025. It will be happening at Argyle Grand Hotel. And the theme of this year is advancing universal health coverage towards attainment of sustainable development goals for 2030. And this will be for Nairobi County. The topic will be driving equitable and efficient clinical research in Africa. This will be taking place Friday at 7 p.m. So do also join us for that, and also invite your colleagues to also come and experience these topics and sessions on KNHUN platform. Dr. Angweni, anything else you'd like to say before we close?
No, thank you very much for having me. Thank you for paying attention. Don't give systemic steroids to psoriasis.
Well noted. I will start keeping that as scripture now.
Thank you.
All right. Now, and also thank you to our participants for joining us and staying with us for up till the end. You are very much appreciated, and we will be sending you notifications on emails for the next upcoming sessions. Thank you once again. Do have a wonderful evening. Goodbye.
Okay. Bye-bye. Thank you.